Let's start. Assalamualaikum everyone. Today I'm going to present on a topic, benign lesions of vocal folds. And I am Dr. Sana Bilal, trainee registrar, Shiksat Hospital, Lahore. Zishan, आगे नहीं जा रहा. First of all, we will talk about the classification. This is the basic classification, which includes non-neoplastic and neoplastic lesions. Non-neoplastic, which is further divided into solid and cystic. Solid, which includes vocal nodule, vocal polyp, Rinke's edema, contact ulcers, intubation granuloma, leukoplakia, and keratosis, while cystic include ductal cysts, saccular cysts, and laryngocele. Neoplastic includes squamous cell papilloma, chordoma, hemangioma, granular, glandular, and rhabdomyoma. Now, in my presentation today, I'm going to discuss in detail solid lesions. First of all is the vocal nodules. What are vocal nodules? Vocal nodules are basically benign, symmetrical, and small lesions which are less than 3 mm, maybe unilateral and bilateral, present on the free margins of the vocal cords at the junction of anterior 1/3 and posterior 2/3, which is the maximum area of vibration and thus subjected to maximum trauma. These are commonly seen in teachers, actors, singers, and vendors. Now, the pathophysiology. Pathophysiology in which trauma to the vocal cords in the form of vocal abuse or misuse causes edema in the submucosal space. This undergoes hyalinization and fibrosis, which ultimately leads to hyperplasia of the underlying epithelium, thus forming a nodule. Predisposing factors include vocal misuse, smoking, and GERD. Now, the clinical features of the vocal nodules include hoarseness of voice, vocal fatigue, pain, and voice breaks at high pitch. On examination, it includes nodules appears as soft, reddish, and edematous swelling, which later becomes grayish and white in color. First, we will give vocal nodules patients conservative management, which include voice rest, speech therapy, and anti-reflex therapy. In surgery, if there are large and long-standing nodules, in adults, excision may be performed using appropriate microsurgical instruments, but other techniques such as laser, like carbon dioxide, can also be used. Note, speech therapy and re-education in voice production is necessary to prevent the recurrence. Now, what are the vocal polyps? Vocal polyps are basically benign swelling more than 3 mm and arising from the free edge of the vocal cords, usually solitary, but may affect. These are more common in young adults who are mostly smokers in male. Why exact cause of polyp formation is unknown. Phonotrauma is an important etiological factor. Sudden onset of hoarseness after shouting, particularly if vocal folds are inflamed from acute infective laryngitis or gastroesophageal reflux. There appears to be disruption to the vascular basement membrane, capillary proliferation, thrombosis, minute hemorrhage, and fibrin exudate, which is the pathophysiology of the vocal polyp. Clinical features and types. It has basically three types: gelatinous, hemorrhagic, and mixed. Gelatinous stroma with fibrosis, while hemorrhagic dilated blood vessels, hemorrhage with polyp, and mixed dilated blood vessels with n gelatinous substance. Clinical features include hoarseness, which is a common symptom, break in voice, lower pitch, large polyps can cause difficulty in breathing, and episodes of choking. And some patients also complain of diplophonia due to different vibratory frequencies of two vocal cords. Now the vocal polyp treatment. First is conservative, and then we will go for surgery.
Medical management is unlikely to resolve the polyps, and
medical management is unlikely to resolve the polyps, but we also have to give patient voice rest, anti-reflux therapy, cessation of
the polyp
speech
is
therapy.
small, early hemorrhagic
While
polyp.
if the polyp is small, early hemorrhagic polyp, then it may be resolved completely with conservative measures. Acid reflux can also increase the hyperemia and causes dilation of the capillaries. Now we will come on the surgical management of the vocal cord polyp, which is basically the microlaryngoscopy and excision of the polyp, and it has two techniques. One is microflap technique, and other is the truncation technique. Now, what is microflap technique? Most polyps need removal under general anesthesia, excising using microsurgical instruments or laser. Microflap excision with the preservation of the normal mucosa is performed for sessile polyps, while truncation excision is performed for the pedunculated polyps. And after this excision, voice rest should be advised.
No, this is the
excision of the polyp. This is the dramatic presentation, which shows first is the elevation of the microflap after giving the incision, then excising the polyp after the trimming of the excess mucosa, and we will redrape the mucosa. And this is the post-op picture of the vocal cord after excising the vocal polyp. This is the DL findings, in which shows first we give the incision over there, and we will excise the polyp from the deep vocal ligaments. This is the final release of the vocal polyp, and this is the inspection of the cord after excising the polyp, and this is the post-op picture of the vocal cords. This is a short video which shows that how we do the microflap technique. This video shows that how we hold the cyst, and now we are going to incise and excise the cyst from its basement. Now, what is truncation technique? This is only for pedunculated polyps, and we will excise the polyp from its peduncle. Now, Rinke's edema. It is also called polypoid degeneration, polypoidal hypertrophy, caudal polyposis, chronic edema of the vocal cord, pseudomyxomatous laryngitis, and smoker's larynx. This is basically accumulation of fluid in the Rinke's space, which is present between the superficial epithelium and the vocal ligament. 10% of benign laryngeal lesions of larynx, and it is usually bilateral. Etiology, it is common in alcoholics, smokers, in laryngitis, vocal strain, and GERD patients. It is common in between 30 to 60 years, presents with hoarseness, and maybe stridor, which is present due to gross edema. On examination, it appears as pale, watery bags of fluid on superior surface of the vocal cords, move to and fro on phonation, and fusiform swelling of the vocal cords. This is the Savick grading of the Rinke's edema. It has 4 grades. One, which is marginal edge edema. Second is obvious sessile swelling. Third is large bag-like swelling filled with fluid. And fourth is particularly obstructing the lesion medial borders in contact along the most of the length. It may be eliminated with it having causating factors like smokers, and we will do vocal cord stripping under microlaryngoscopic surgery, and voice therapy and rest should be advised after the surgery. This is the diagrammatic presentation that how we do the vocal cord stripping. It is indicated when there is gross edema and causes choking and pitch elevation of voice is required. The principles of surgery for Rinke's edema include reducing the bulk of the mucosa of the vocal fold by using microspot laser. The myxomatous material from the superficial lamina propria layer is aspirated, either removed with forceps or vaporized, and the epithelial edges opposed following excision of the dependent mucosa as necessary. This is the vocal cord stripping, which is shown in first picture, then removal of edematous tissue. Then we will redrape the mucosa, and this is the pre-op and post-op picture of the vocal folds. Now the contact ulcers. This is also called as pachydermia and contact granuloma. Ulcer is basically a misnomer as the overlying epithelium is intact. On clinical presentation, patient having low pitch and hoarseness of voice, saucer-like lesions, thickened epithelium within central indentation at the site of mucoperichondrium, covering the medial surface of the vocal process. Etiology, basically it is common in vocal abuse, gastric reflux, obsessive clearing of the throat. Treatment include voice therapy, psychological therapy or stress therapy, and anti-reflex therapy should also be given. While surgery include microlaryngeal excision of the granuloma. Now, the intubation granuloma. These are basically mushroom-shaped pedicled granuloma present on the medial surface of the vocal processes and more common in patient with prolonged intubation. After giving medical therapy, surgery is indicated. Its pathogenesis include long-term intubation, which leads to pressure necrosis, and in the end, reactive granuloma may be formed. And surgical, which includes microlaryngoscopic excision. Now, the intracaudal cyst. These are basically two types, mucus retention cyst and the epidermal cysts. Mucus retention cyst, also called the ductal cysts, arises from the blocked minor salivary glands, possibly secondary to the phonotrauma or inflammation. It is usually unilateral and is found on the free edge of the vocal fold. Epidermoid cyst filled with keratin and cholesterol debris. It may be formed due to vocal abuse over the buried epithelial cells. Patient may present with hoarseness of voice, and therapy, surgical treatment should be given, and excising the mucosa and cyst and avoiding leaving a part of wall behind. And post-op, we should have to give patient voice therapy and rest. This is the picture which shows that how we excise the mucus retention cyst. As this is shown by a dotted line, we have to give incision here, and we have to excise the retention cyst, and this is the post-op picture. This is done by basically a microflap technique. Now, what is bamboo nodes? This is basically common in autoimmune diseases. These are round, pale, yellowish lesions, and we have to go for testing, which includes RA factor, ANA, Sjogren antibodies, and traced ESR should be found. And treatment includes conservative, in which we have to give speech therapy, systemic steroids, and vocal fold steroid injections, and in the end, we have to excise the node. Vocal cord leukoplakia or keratosis. These are basically white plaque which is present on the vocal cord that cannot be scraped off. These lesions have the potential to evolve into carcinoma in situ, most common in males, adult males who are smokers. Pathologically, there is thickening of mucosa, some mucosal edema, hyperplasia, hyperkeratosis, dysplasia, and epithelial atypia. Symptoms may include hoarseness and constant feeling to clear the throat. On examination, there is mobile vocal cords with a thickened white area, which is seen on the laryngoscopy, and treatment is patch. Now, the vocal sulcus. This is basically a groove along the mucosa, and this is due to the weakness of muscles. And it has three types, which includes physiological or pseudosulcus, sulcus vergator, and sulcus vocalis. First is the physiological or pseudosulcus, हम्म। Now we come on the phonomicrosurgeries, which include microflap technique, which I already discussed in detail in my previous slides. Now the laser microsurgery. It includes carbon dioxide laser, which is most commonly used laser in the laryngeal microsurgeries. And it is best used in vascular lesions or lesions that bleeds on removal, such as papillomatosis or granulomas, removal of the cartilage, vocal cords, cordotomy, and excising the large areas of the tissue. It has advantages. It gives us better vision of the operative field with minimal tissue manipulation, decreased risk of post-operative bleeding, and it provides better intraoperative hemostasis, while in disadvantage, it is cost effective. There are into photoangelic lasers and cutting or ablating lasers. Photoangelic lasers include KTP and PDL, which is pulse dyed laser, while cutting and coagulating lasers include carbon dioxide and thallium. Carbon dioxide lasers are more focused than all these types and most commonly used for the laryngeal pathologies. PDL, which is pulse dyed laser with wavelength of 585 nanometer, while KTP with 532 nanometer lasers. These are office-based photoangelic lasers. Now, the angelic laser surgery. Angelic laser surgery can be performed via flexible transnasal endoscope under the topical anesthesia in an office setting. First, the larynx and the pharynx were anesthetized with 4% topical lidocaine spray. The laser was delivered to the lesion through a flexible optical fiber attached to the endoscope. The beam was centered just above the surface of the lesion without actually contacting the lesion with the tip of the fiber. The procedure was completed when the color of the hemorrhagic polyp changed to white, and the patient were instructed to be on complete voice rest for just 1 day. In this technique, we use a green laser with 532 nanometer wavelength to photocoagulate the vocal polyp at a power of 1.5 watt. This is a study which shows the comparison of vocal outcomes after angiolytic laser surgery and microflap surgery. This is a current retrospective study which suggested that angiolytic laser surgery was as effective as microflap surgery for the vocal polyp, but it is benefited for those patients who having comorbidities and can't go for general anesthesia and unfit for general anesthesia. So it can be performed in office under local anesthesia. This is the measurement of the vocal polyp, in which L shows the length from the anterior commissure to the vocal process, where A is the area of the vocal polyp in a stroboscopic or endoscopic image is shown in there. The vocal polyp size was defined by the formula A over L square in 200. This is a video. Uh, this is a video of how we excise the cyst from by laser, and we have to hold the cyst, and we will do laser and excising the vocal, uh, excising it from the vocal cord. This is the pre-op and post-op picture after laser. This is the capillary ectasia. First is the pre-operative microlaryngoscopic image of the capillary ectasia, and after using pulse dyed laser, this is the post-op picture. Now, the laser precautions and safety. Laser heat can cause scarring and causes damage to the adjacent tissues. With lasers, there is a potential for the endotracheal explosion, facial burns, mucosal burns, vocal folds, webs, stenosis, and glottic incompetence. Endotracheal tumors can cause sepsis, This is a short video which shows that how debrider works. Uh, this shows that a papillomatosis which is excised by using a micro debrider. And it excises all the papillomas which is present at the anterior commissure. Now the laryngeal cobblator. Coblation-based bipolar plasma devices are designed to operate at a relatively low temperature to gently dissolve and to shrink target tissue with minimal thermal damage to the surrounding healthy tissues. Coblation technology provides ablation, resection, and coagulation of the soft tissue and hemostasis of the blood vessels in one convenient surgical device. Coblation technology can be used in larynx and trachea for removing or debulking sessile polyps, lesions, or tumors. It is minimally invasive. Coblation technology can offer less invasive treatment with quicker recovery and shorter hospitalization. This is a short video which shows that how cobblator works in endoscopic vocal cord polyp excision. In this video, which shows that we have to first hold the polyp and using the cobblator and excising the polyp from its base. And this is the post-op picture. This is the pre and post-op pictures after using the cobblator. This is the pre a picture which shows papillomatosis, and we after using the cobblator, this is the post-op picture and showing the normal vocal cords. Thank you. So the patient will mostly complain of vocal fatigue and hoarseness of voice. And there is must history of vocal abuse. So change in voice होगी, लेकिन it may lead to hoarseness of voice if there is a larger nodule present.
Especially when they go on vacation, the voice becomes better. And when they start working again, it starts becoming more. So I think when the patient comes to aesthetic,
you can tell that this patient has got this disease. Just to, in my own experience, if a patient of nasal polyp in the nose, I don't know what is that change, but that change has trained my ears over a period of years that this is a voice of the they can alternate always, and you can use both of them. I don't think there should be some confusion. ये क्यों है और ये both sides the change of quality of voice. My voice may be different. I think the voice of every individual on this earth is as different as your thumb.
Both are fine. Focus on that way that maybe it's a change of voice or portions of voice, or portions is a different attitude.
I think they can be interesting. Both of them are all right. Both of them, you can say change of quality. I think this is minor. You can say change of quality. This is the gravity is more. You can say this, of course.
So
okay. Somebody have a dysphonia, just like dysphagia, difficulty in speaking.
So the problem is very simple. So वो मरीज तो आके कहेगा कि मेरा गला खराब है, लेकिन जब आपने उसे प्रेजेंट करना तो आप ये दोनों सुनते कैसे? So come to the vocal review.
Another, when the patient comes with the complaint of the patient got tonsils,
right,
and he has been seen by some doctor, by some colleague who is sitting at a place where there's no microlaryngoscopic facilities are available. And in our society, we people, we doctors, I blame myself as well, probably. We want to do something for the patient, and we do want to do some procedure. And many patients, they undergo unnecessary surgeries when they are diagnosed as tonsillitis, but they actually have some other disease. They have got ear disease and have been operated in the nose. Somebody can't do mastoid, he operates in the nose, he operates the throat. Patient goes 2 to 3 surgeries, but the actual problem remains there. So be very cautious. Even if the patient says कि मुझे tonsil है या इस बच्चे को tonsil है, must you at least छोटे बच्चों में laryngoscopy करना is a bit difficult, but always let him talk. I usually say कि कोई आयत वाला सुना दे. You can always have an idea कि patient को actual क्या complaint है.
So
And exactly जो nose के अंदर भी ऐसा होता है कि बाहर से hump है, वो कैसी हड्डी बड़ी हुई है मेरा नाक का, नाक बंद नहीं होता, but anyhow उसकी perception different है, doctor की perception. One has to be, I mean, you have to inquire properly. थोड़ा उसमें आपको tonsil को tonsil ही हमेशा नहीं समझना. There could be something else.
So tonsil has no role in the voice problem.
Yes, infonation.
Tonsil is a infective disease, so that's a totally different entity. Tonsil have no concern with voice. So, sir, ये जो trimming of plateauglossus.
मैं एक छोटा सा ये कहना चाहूँगा कि probably tonsil has no role in phonation,
Right.
but tonsil has role in voice as well.
Yes.
When the tonsils are grossly enlarged, then there is a hot potato box, and the patient gurgles in the throat. So it has got some effect on the voice, but it has got no effect on the phonation.
सर जो है प्लेटोग्लॉसिस या प्लेटोफ्रेंजिस, इनका कोई रोल तो नहीं है?
Platoglossus and platopharyngeus, not much, not much really. I haven't seen anybody, patients, both pillars, they have been damaged by us, and the whole anatomy of the pharynx is changed after tonsillectomy. But there is no change. I think usually there is no change in the quality of voice.
मैंने अगर बच्चे की एडिनोटॉन्सिलेक्टमी तो पेरेंट्स को पहले बताता हूँ कि उसके बाद कुछ आवाज बदल जाती है क्योंकि वो चैम्बर खाली हो जाता है।
Exactly.
तो ये पेरेंट्स में आगे कहते हैं कि थोड़ी सी आवाज बदल गई है बच्चे, मैं कहता हूँ कि अभी ये नॉर्मल हो। ठीक है, चल नेक्स्ट।
एडिनोटॉमी करने के बाद ना मोस्टली कंप्लेंट हमारे पास आती है कि बच्चे की पहले तो आवाज हो तो अब चेंज हो गई, क्योंकि द रेस्ट ऑफ टाइम पे
So adenoidectomy is contraindicated in one condition. What is that?
Left.
soft left side
Submucous cleft palate. ठीक है, एक पेशेंट को मैंने देखा कि उसकी जब भी ये सबम्यूकस क्लेफ्ट पैलेट होगा, अगर आप उसकी एडिनोइडेक्टमी कर देंगे तो क्या होगा, खत्म हो जाएगी बात, अजीबोगरीब हो जाता है। I don't know, it's reversible or irreversible, sir?
Actually, this is not reversible at all. But you can always build posterior pharyngeal wall,
Right.
At the where the palate touches the posterior pharyngeal wall. You can augment it a bit, raise a flap inferiorly, and then fold it and make a flap. Then you can decrease or reduce the leakage into your nose.
So come to the vocal pathology. हम कहीं और जाते जा रहे हैं आस्ते-आस्ते। बताओ जरा अगली स्लाइड है। बस ठीक है, ऐसे ही दिखाते हैं। So vocal nodules में तो सर आप कितना वॉइस रेस्ट एडवाइस करते हैं after the surgery? So what is your strategy for dealing a vocal cord nodule?
For not more than 7 days.
Okay.
Not more than 7 days. I think the more important thing after doing any proper absolute voice rest, it should be the advice should be the patient should not whisper and the patient should not shout.
Shout, right?
Whispering, I feel whispering is more dangerous, more harmful as compared to shouting.
Right.
You strain more on your larynx when you whisper.
So voice rest means
a voice, I tell them not to speak for a 1 week,
okay.
But in future, always don't shout and don't whisper. Don't
Right.
whisper. Okay. That is for lifelong. Don't strain your larynx by whispering and by shouting.
And speech therapy is the integral segment of the treatment.
Usually, yes. Usually, yes.
चलो ठीक है जी, vocal cord nodules में voice whispering is not allowed. Whispering normal voice, it is low tone, and speech therapy is the integral part of the treatment.
And especially teachers, if they address a larger classroom, they can close, they can come forward. If it is smaller and if it is a larger room, they use some audio system to address your students. इस तरह हमारे classrooms बहुत बड़े-बड़े होते हैं, तो उसमें at time ये facility available नहीं होती, तो advise them to use some.
सर हमारे डॉक्टरों को गाइड करिए. Suppose if we are excising the vocal cord nodule, so what is your concern? जब हम एक्सरसाइज करते हैं तो what surface you focus that has to be excised? With a bit segment of the epithelium or basal lamella, superficial epithelium, or to excise the exact nodule?
in laryngeal surgery, I feel you please do not do more,
Right.
and do not do less. It has to be precise surgery. So, doing any kind of voice surgery without microscope or without endoscope is it should be contraindicated. You can strip off the mucosa. There is no problem. It regenerates and it regrows very quickly. But be very precise. Remove the nodule only. Please do not remove the vocal cord. You can take out a bit of mucosa. That usually doesn't matter much in my experience. But naturally raising a flap and taking it on, they are definitely preferred. But even removing the part, the laryngeal surgery is very, very skill job. Right? The instruments are too long and they always vibrate, and they always, you really can't even hold a nodule very properly at times. और शायद मेरी एज के अंदर या जो बूढ़े तो हमारे ट्रेमर्स भी शायद थोड़े बहुत हो जाते हैं, बट आई फील इवन एट अ यंगर एज it is difficult to hold and work in the larynx very precisely. So you have to, touch your instrument somewhere within the scope to make it stabilize, right? So that it doesn't move like this, because it's a very long instrument, and the end of you are working with the far end, and it usually goes here and there. So you have to be a bit careful not to touch and not to injure the other structures around.
So the appropriate instruments are the knives and scissors.
Yes, knives and feathers.
Rather than forceps.
Yes.
Not pull.
Yes.
Just inside.
Be accurate. Be accurate. Be accurate.
Chale, next. Yes, please.
How much conservative or voice therapy would you advise pre-operative? Like we do say that voice assistant should be given for positive traumatic process. So how much?
So you better so is the
Conservative. He is talking about the conservative, right? I think if the nodule of more than 1 millimeter, 1 millimeter is quite big. Usually they are up to 3 millimeters. They are not bigger than that. But anyway, they are very small nodules. Then you can go for voice training, speech therapy. You have to incise them most of the time. I don't think if they're very, very minor, or वो आपको पता चल जाता है, बहुत छोटे-छोटे भी होते हैं, and then you can advise them to have some kind of speech therapy and use their voice properly, whisper नहीं करें और loud shout नहीं करें, so probably they will. But if they are more than bigger than 1 mm, I think ideally they should go for surgery as soon as possible.
So the treatment of chronic laryngitis is a conservative treatment. But if there is established nodule, then the treatment is a surgical treatment.
उन्होंने मतलब bookish तो ठीक है, मतलब, but I think they should be very small. Right? If you go for the conservative treatment, if they are more than 1 millimeter, I don't think किसी भी तरह का speech therapy.
How long would you prescribe speech therapy in, let's say, 1 millimeter proceedings? That this is a threshold of
Maybe 2 months.
Thank you. So come to the vocal pollen. So the voice will be the same. Change of voice or sourceness. Sir, हमारी जो last थी हमने पोशीसा को लाया था laryngeal paralysis पे हमारी presentation. So what you do fiber optic or you do 72 degree? And what should be the standard?
I think nowadays no ENT clinic is possible without 70 degree, and ideally you should have a fiber optic. If you don't have fiber, because in 30% of the patient you read with all the efforts. Mirror to dur ki baat hai, with 90 and 70 degree you can't see the difference. The anatomy is like that.
Yes.
That your it falls back. Overhanging epiglottis. You really can't find. You can't see the every nook and corner of your vocal cords. So fibro-optic is part of. Because I do clinics at two places, so I keep fiber-optic in my car because I have to carry from one place to another. It has to be whenever required. I call and गाड़ी से मंगवा लेता हूँ. I think I try to see every patient with the 70 degree. और अगर उसमें कोई शक शुबा हो तो definitely हर patient के लिए, because fiber-optic we do charge for that, and with normal with 70 degree or 90 degree not charge patient for everything. तो उसके लिए फिर अगर वो फिर कहें patient के मैंने देखना है, तो I usually tell them you have to pay for that. अगर आप खुद भी देखना चाहते हैं, मैंने देख लिया, my findings are this. तो कई दफा उसके साथ भी हम कैमरा लगा के दिखा देते हैं वैसे तो, अगर इजी हो, लेकिन उसके थोड़ा सा डिफिकल्ट हो जाता है उसका क्या.
Actual 70 degree is easy, like in our busy OPD
Yes.
in government system.
In any system, even in, मतलब मैं कहता हूँ कि अगर if you're charging for that, if you're charging in private sector, so I think if you have seen and you're sure, you can always explain. I have seen, and I'm sure this is a disease. And if you want the fiber optic to be done, then you have to. If they have to pay, if you're willing, you can. And if you want to see, then it is your choice. But मेरा ख्याल है कि या फिर आप charge ना. If you are not charging, then go for fiber optic every patient. Ideal तो.
हमारे पास 70 डिग्री है, वो ऊपर में करते, लेकिन मैं शिफ्ट कर रहा हूँ फाइबर ऑप्टिक. ऐसा डिफिकल्ट जिसमें उनको मैंने अब वो फाइबर ऑप्टिक पे चार्ज कर रहा हूँ कि ये दोनों प्रोसीजर आने चाहिए. और सेकंड जो सबसे इम्पोर्टेंट बात है, कभी भी किसी के एग्जामिनेशन, किसी की फाइंडिंग में कभी भी ऑपरेट ना करें. डू बाय योरसेल्फ 70 or fiber optic, make your own diagnosis. I haven't received twice a breeze देखा हुआ था, and I missed in the surgery because the patient has vocal polyp just below the anterior commissure, and I missed it during the surgery because surgeon has known that there is a growth on the left vocal cord. And left vocal cord देखा, it was slightly thicker, but there was no gross pathology. But at that time, I just excised my because and I came out. And after the surgery, the patient seemed complete. And the patient was a great preacher of Christians. So when he wake up, he has same voice.
No, you have I mean, fall in trouble at times. I can quote two patients. At times, if the vocal polyp is very much pedunculated, you can cough it out. It goes away. It naturally, it is removed by nature. Patient came, I saw, and I couldn't find it. Because patient book was for time appointment, he came to the theatre. वहाँ तो दोबारा नहीं देखा पेशेंट को, जब आया इंट्यूबेट हो गया, देखा तो actually there was, because he just had coughed it out and never knew that he had, and he told that his voice had improved. लेकिन उसने कहा कि जब वो ठीक हो गई थी, लेकिन मैंने कहा डॉक्टर साहब ने ऑपरेशन बताया हुआ तो करवा लेना चाहिए. And another time, I was posted in CMHO Kada, and there was the patient was a colonel, and he had got a vocal problem. We were two doctors over, two specialists were there. I really couldn't find problem, as you said. I had seen myself, and I called the other guy, and he saw it. And we kept on searching, and we extubated the patient. In the evening, after 3 hours, when we go for the private practice, I went to his room, and he other way around, he said, "Also, मेरी आवाज ठीक हो गई." मैंने वहां पे कोई कमेंट नहीं किया, but I called him कि आप मेरे लिए महाराज, I saw him and the polyp was there.
Polyp was there.
बस नहीं मिला. तो उसके बाद फिर उसको दोबारा बताया कि जी इसकी होनी है, तो दोबारा इसकी उसके साथ नेचुरली जब किसी का भी ऑपरेशन होता है, घर वाले भी गए होते हैं, अच्छे से पेरेंट्स वगैरह, कोई फौजी दूर दूर रह रहे होते हैं। तो उसका एक भाई था, he was in young students, young doctors association का जनरल सेक्रेटरी टाइप था लाहौर, बड़ी बड़ी थी उसकी। और उसने कहा कि जी नहीं, अब सब ये कैसे हो सकता है, आप कल आपने अरेस्ट आपको मिला कि मतलब थोड़ा सा आई रिमेन काम। तो मैंने कहा यार ये दूसरे डॉक्टर को भी दिखाया था, इनको भी, दैट इज देयर, मुझे नजर आ रहा है। और मैंने नहीं निकाला था, मैं आपको कह सकता था कि आप श्योर थे कि मेरी आवाज इम्प्रूव हो गई है, और आप किसी इनडायरेक्ट लेरिंगोस्कोपी आप कम से कम 2-4 महीने बाद ही कराते, तो उतनी देर वेट कर रही है, अगर मैं मतलब आपके साथ अनजस्ट भी कर सकता। तो बट एनी हो, इट वाज वेरी डिफिकल्ट एंड द पीपल देन, मतलब उन्होंने कहा डॉक्टर अच्छा है, आप इससे कहा जी अगले दिन फिर एनेस्थीसिया उसी दिन दोबारा एनेस्थीसिया देते थे। But anyhow, he agreed and I did it, and he was thankful. So, well, these things do happen in life, and do expect. ऐसा नहीं है, it is not 100% happen. ऐसा ही है, according to the book. There are variations. You may fall in trouble, but be sincere to your patient. Whatever is there, tell them. Complication हो जाती है, tell them. ये हो गया, this is that. I confessed कि जी मतलब था, मौजूद था, सारी बातें दोबारा तो नहीं बनाना मतलब वो कपल ऑफ, और था, हमें नहीं मिला, हमारी नालायकी कैसे।
So it means make your own diagnosis.
Yes.
अब इन हमारे डॉक्टर साहब ये करके दाखिल करो, फिर भी डे बिफोर पहले इनको कहते हैं कि 70 डिग्री कर, इसका प्लान दोबारा कर, ताकि वो चीज मिस ना हो दोबारा। सो
बोले
डे बिफोर पहले कहते हैं 70 डिग्री कर, सो ये किन पेशेंट्स में ज्यादा होता है?
Sir, most common in smokers in adult age, in males, it's with chronic vocal abuse.
साइड की वजह है और इस पूरी से कहता है कि जी मुझे हो गया, तो उसको क्या कहें?
सर बस उसको नहीं बताएंगे कि आपके पीछे क्या इटियोलॉजिक फैक्टर्स थे, तो उसके रिगार्डिंग तो उसकी मस्ट हिस्ट्री होगी वोकल अब्यूज की, और स्मोकर मेल कॉमन इन मेल्स विद इन एडल्ट।
So now a known factor in these pathologies like chronic laryngitis, vocal cord edema. So I think so anti-reflux treatment must be the part of all these treatments. As I do you agree?
not really,
Not really.
not really. If the polyp, then why did it touch only the one vocal cord, and it didn't touch, because it's a unilateral disease 99.9%. And why the gastric acid didn't touch the other?
So this is a different end. That is pertaining to the chronic laryngitis.
Yes, chronic laryngitis is okay. Voice abuse for vocal nodules is okay, but I think any for the mucus retention, the laryngeal polyp, you can blame these things that they are because of
pathological problems.
pathological.
Next pathological problem. अच्छा सर, बच्चों में बड़ा डिफिकल्ट होता है, पेरेंट्स आते हैं और बच्चे होर्स भी होते हैं, सो आप कैसे डायग्नोस करते हैं?
यही होर्स बच्चों में टॉन्सिलाइटिस है।
नहीं, आप कैसे डायग्नोस करते हैं? आप जैसे बड़ा मुश्किल होता है फाइब्रोमेट्रिक करना 4-5 इयर्स के बच्चे की, सो हाउ यू मेक द डायग्नोसिस? व्हाट डू यू डू?
Frankly speaking, I use cat in the clinic. थोड़ी सी, हाँ, but just हो जाता। Even you put some of few drops of ketamine in the nose, the patient goes to sleep.
Then you do the fibromyalgia.
You can.
हमारे डॉक्टर क्या करें, इनको भी गाइड करें।
Ketamine ना लगाए।
Ketamine is a drug.
Well, a patient, see the patient at that.
Yes.
Yeah. देखो आपके पास when the patient comes with hoarseness of voice, or if the patient comes for tonsillectomy, please speak to the child. Let him speak and talk to him. मतलब do not talk to him. Let him speak. उनको बच्चों को पेरेंट्स को बच्चे आपके सामने नहीं बोलते तो पेरेंट्स से अपने से बात करें. Just listen. ठीक है, उनकी वॉइस ट्रांसफर करने से पहले हमेशा पेशेंट की वॉइस को जरूर सुने और कुछ भी ना करें.
So ultimately, you can diagnose only on the
Oh, yes. Under
GL.
Yes.
So explain to the family
Yes.
that the patient may, you can miss the juvenile laryngeal papilloma.
Yes.
If अगर उसे persistent voice है और उसकी significant history है, तो फिर अभी कभी भी दवाइयाँ लिखने की कोशिश ना करें. Make your diagnosis. Do the microlaryngoscopy.
Do the laryngoscopy at least. May not be microscopic, but do the minimum laryngoscopy. And in papillomatosis, I was called to see a horse patient in the ward. Naturally, उसको horse भी था, थोड़ा बहुत उसको dyspnea भी. So when I went to the ward, patient in front of my eyes, he went into apnea, small child. और मुझे कुछ नहीं सूझी, मैं उसको जनाब अपने हाथों में उठाया and I was running and the child's mother was running behind and take him to the theater. Did the tracheostomy. Patient was absolutely happening. And वही 2, 3, 4 मिनट 5 मिनट के अंदर it saved the patient. तो सिर्फ actually it has got two functions of phonation and respiration. See, talk about the voice, talk about the कई patient, see वाले patients, don't judge their hoarseness, judge their patency as well.
Right. Next, vocal polyp हो गया. अच्छा.
So patient के पास lesion हो like a polyp or a papilloma. So what tips are advised so that a subglottic web can be avoided or that the complications can be especially bridge gate.
Yes, you're right. I think the lesions, usually most of the lesions, except the papilloma, they are unilateral. They're not like cancers. They can be bilateral. Papillomatus, they can be bilateral. But these the other things, they are all unilateral. हमने कोई भी नहीं देखी कि भाई cyst है तो unilateral है, polyp है तो unilateral. They're unilateral. And be precise. Be specific. Just जितना accurate and precise होंगे, do not remove more, do not remove less. Just confine yourself to the same. मैं डॉक्टर साहब से भी बात कर रहा था कि बहुत सारी चीजें which काम जो मौजूद होती हैं, we really can't see. After around, मतलब अभी तक मैं आप अभी तक भी कह सकते हैं, I started ENT in 1990. I started training in 1990. In the army, used to do training and then हमारा एक grading हो जाता. 1 साल की training के बाद comes specialist. Then I remained posted as a specialist as well at 2 places, and then I did start, or rather 3 places. Then I started FCPS part. तो वो मतलब एक अलग इशू है, लेकिन उस सारे प्रोसेस के अंदर जितना आप ज्यादा देखेंगे, आप उतना ज्यादा the things they are there. The anatomy of the ear is very, very complex, and every time और 25 साल बाद मैं ये कहता था, यार ये चीजें पहले तो हम समझते थे शायद सिर्फ किताब में होती है, बंदों में नहीं होती. तो अल्टीमेटली यू स्टार्ट सीइंग एंड एवरीथिंग इज देयर, और वो दिखने में देर लगती है, तो आप जब देखते रहते हैं ना, और आप थोड़ा सा अपने आप के माइंड को खोल के लुक, ENT का एग्जामिनेशन जैसे आप एग्जाम में करते हैं, प्लीज डू लाइक गिव सम टाइम टू वो बेचारा चल गया है, उसने वेट किया, रिस्पेक्ट। आपकी रोजी उसने लगाई, रिस्पेक्ट, बी लॉयल टू योर, बी सिंसियर।
Sir, what are the possible complications while doing the microendoscopy? Like, I have never seen the retinoid dislocation, like sort of thing. Is it possible, and how is it possible?
I haven't seen, because जो माइक्रोरेंगोस्कोपी, हम जो लेरेंगोस्कोपी कर रहे होते हैं, we do it with the tube in, and we really can't see that.
So
We
that is
really
protected
can't
with the tube.
Oh, yes. So we can't even see that area. Have you ever done laryngoscopy without without endotracheal inturbation?
Yes, we do in this session. We do in FDM.
So you do it in that. There was a patient. You know what is venturi? Have you seen venturi? Ventilation? Okay.
Jet
Yeah.
ventilation.
Jet ventilation. But I haven't seen in Pakistan so far jet ventilation. आपके पास है?
हमारे पास सिस्टम था, लेकिन अब collapse हो गया.
Collapse.
लेकिन उससे पहले हम करते थे jet ventilation.
Jet ventilation. Yes. In London, in St. Bart's, I was working in St. Bart's, and anesthetist, he passed a very small tube inside उसको लेके, so he put beyond the lens. He gave the pressure, jet ventilation, and both lungs busted. He had got bilateral pneumothorax patient. So जो चीज आप यूज करते हैं, मेरा ख्याल उससे पहले बहुत सारी उसकी जो इंट्री केसेस होती हैं, बिकॉज यू डू जेट वेंटिलेशन, यू पुट अ प्रेशर ओवर देयर एंड इट इज टू वर्क ओवर हियर, सो द प्रेशर विल बी मच मोर. तो उसने उसके साथ एक ट्यूब लगा के उसने उसको लेने से बियॉन्ड कर दिया. अब वो प्रेशर इतना था कि उसने दोनों लंग्स के उसको न्यूमोथोरेक्स. तो मतलब आपके पास जो चीज, ये वाला जो तरीका है, यू कैन डू इट विद जेट वेंटिलेशन, विद वेंचुर. अगर आप रेटिनॉइड्स को भी देखना चाह रहे हैं और वहां के लीजन और पोस्टीरियर पार्ट ऑफ द लेरिंक्स के लीजन को ट्रीट करना चाह रहे हैं, they are possible with jet ventilation.
So luckily all pathologies
Yes.
formation.
Usually, all तो नहीं कह सकते, but most of the pathologies they are.
Next thing, अगली slide check now. हमारे पास बड़े अच्छे एनेस्थेटिस्ट थे सर, डॉक्टर नुमान, एक डॉक्टर मुबशर थे. जब हम रेजिडेंसी कर रहे थे, उनके पास ये सारा इंतजाम करते थे. वैसे अब्दुल
हाँ,
जेट वेंटिलेशन पे बड़े केस कर.
हाँ, मतलब मैंने नहीं देखा.
हमारे पास
नहीं होगा डेफिनेट. अच्छा, वो इतना बड़ा, देयर आर टू टाइप्स ऑफ जेट वेंटिलेशन, और उसमें एक तो मशीन है, वो दैट गिव्स प्रेशर, एंड अदर इज जस्ट हैंड manual. That is just like a piston. You do it like this, and it explodes. वो pressure दे. तो वो एक छोटा इतना सा इंस्ट्रूमेंट है, just like a piston. तो आप उसको यूं करते हैं और वो pressure. So they're a very small thing, but I haven't seen here in Pakistan. Yes, do it.
The stripping.
Yes.
With the micro scissor.
With the micro scissor.
So you will move all the redundant because of sparing the anterior commissure.
Sparing the anterior commissure as much as possible.
As much as possible.
इन लोगों के अंदर ना इतनी ज्यादा होर्सनेस होती है, अगर थोड़ा बहुत anterior commissure involved भी हो जाए, still there is problem.
ठीक है.
मतलब ये भी काफी bilateral disease है, तो bilateral disease में chances होते हैं anterior commissure.
जो मैंने देखा, ये बड़े वो फैटी प्लीजों में ये ऐसा होता है. ये नेक भी बड़ी डिफिकल्ट होती है.
Yes, neck is also difficult. It is in the fatty patients. I lost a patient of Franke's edema post-operative. जिस तरह हमारे theaters में the patients, we are in hurry कि इस patient को निकालो यार, anesthetist in hurry. The patient was, after the surgery, the patient was shifted to the recovery, and it was probably not very well manned. And after I did a surgery, went to my clinic, and after about 1.5 hours, I received a call that your patient is dead. it is not because of the edema. It is just because of lack of management of anesthesia in their case. वो थोड़े मोटे लोग होते हैं, they've got breathing is a bit difficult for them. So I lost a patient just because of lack of anesthetist. It was on the part of anesthesia, but I knew I owned the patient.
Contact ulcers. Next thing हमें intubation granuloma is easy to treat. Cause is intratubular intubation. Intercordal cyst.
Yes. इतनी हो जाती है आपके पास. I've seen couple, not much.
अच्छा सर ये
वैसे ना मतलब फट जाती है. हम किताब में तो देख के कह देते हैं या तो हम बहुत ज्यादा कर रहे हो तो then it is okay, but during handling it is very difficult to maneuver your instruments in the larynx. I'll again say because they are very long और उनको कंट्रोल करना मुश्किल है.
अच्छा सर अभी एग्जाम पे मैं गया तो मेरे साथ एक बड़े सीनियर एग्जामिनर थे, उन्होंने कैंडिडेट को वो कर लिया. उसने आइडियल की देयर वाज ए पॉलीपेडल mass on the vocal cord. So short case, what is this? So examine किया, so this is a vocal cord, vocal polyp. Now how you know this is तो मतलब ये है कि obviously जब हम फाइबर ऑप्टिक कर रहे हो या हम देख लेते हैं तो काफी माइंड मेकअप हो जाता है. सो क्या उनका नजरिया ये था, वो कह रहे थे कि दिस इज द हिस्टोपैथोलॉजिकल diagnosis. So you can't say this is, so you must say vocal cord growth. आपका क्या नजरिया है ये इनके रेजिडेंट में?
I do agree to some extent. The reason being the way I explain to my patients, I naturally write vocal polyp and I may put a question mark in front of that because naturally the diagnosis is histopath.
उन्होंने एग्जाम भी पास करना है इसलिए पूछते हैं.
नहीं तो बस कह रहे it looks like you
Looks
can
like,
mostly I usually say the way I communicate with my patients, I tell them that your disease is, I feel this is your disease and I mean very benign as I think I feel that आप बहुत शरीफ आदमी है but I really don't. मुझे आपकी शराफत को चेक करने के लिए I have to check from your workplace and from your living place क्या आप कैसे हैं. तो उसके लिए मुझे तो हमें इसको ये देखने के लिए मुझे लगता है कि ये सीरियस है और ये चीज है, but to confirm it we need a confirmation from the laboratory and that can be taken out. It should be taken out and sent to them. So, and एक और चीज I like to share कि एक जो important चीज है जो मैं बार-बार ये कह रहा हूँ, never overdo and never underdo. Try to be precise and accurate. मैं एक पेशेंट था, it was looking just like a cancer, very small on one vocal cord, and I told him that पहली दफा अगर मैं बायोप्सी लूंगा तो मुझे लगता है कि ये सीरियस है. तो if I इतना छोटा है स्टेज के ऊपर, if I remove it with a bit of vocal cord, then your disease is going to you'll be okay forever and you may not require any other treatment. And I did it. And it turned out to be tuberculosis. Right? And tuberculosis. And the patient had got permanent worse. I think I was wrong. I should have taken the not bad to put the patient to sleep, but be calm. Right. Be accurate.
So exam में आपको चाहिए it is a right vocal cord growth. That is that, right? Secondly, this is keep the high suspicious tuberculosis. Cough for उसके अंदर अगर ulcerative lesion
नहीं, it was on the what? मतलब proper उसके ऊपर not on the posterior. वो बिल्कुल छोटी मतलब थी to my eye, जैसे मैं कहता हूँ कि पोलिप के मरीज की आवाज से पता चल जाता है, तो इसी तरह मतलब आप लेकिन ये नहीं कर सकते आप उसका नाक और सीटी स्कैन देख के बगैर उसको पोलिप कह तो आपको उसको जो भी चीज है आपको उसको डायग्नोस करने के लिए यूनिट हिस्टोपैथोलॉजी अच्छा and the voice and the your it is so sensitive organ and so specific कि हर बंदे की वॉइस डिफरेंट है फ्रॉम अदर मतलब यू कैन रिकॉग्नाइज हिम फ्रॉम वॉइस और इसके अंदर even a very minor change in your record is important. थोड़ी सी भी चेंज आती है, give it credit और उसको देखें, उसको investigate. It is so sensitive. When you sleep, there are minute changes in your larynx, probably a bit of edema, and your voice changes. Even you talk to somebody on telephone who is sleeping, you can detect that the person is sleeping. तो इतनी जो चेंज वो नाइट जो आपकी स्लीप से आती है, दैट इज ऑल्सो अप्रिशिएबल चेंज. वो कितनी की वो चेंज हो.
सर वोकल कॉर्ड को प्ले किया, so obviously we keep the high suspicion of malignancy. So what you do the stripping, laser ablation, what do you do? Because leukoplakia is a difficult disease.
Very difficult.
कैसे इसकी बात है? क्योंकि obviously you have to take small. ये यहाँ पे खाएंगे नहीं, पर ऑफिस में
उसकी बायोप्सी
पहले ट्रीटमेंट चाहिए सर, टिपिक करनी चाहिए.
देखिए, I had this facility, laser facility available only in PD for some time. So I never had the facility to have laser. Probably लाहौर में कितने लेजर हैं?
हमारे पास है.
कितने लेजर? 2 लेजर आपके पास है. तो चल any of well very few people have the access to this facility. Stripping, but a conservative stripping, not damage much. क्योंकि कैंसर होना तो एक अलग बात है, इसको ज्यादा खराब था.
तो जो बायोप्सी लेते सर बाइट तो कॉर्ड पे हो ही जाता है.
यस, पर जितना पॉसिबल है, मैं उसको आपने बायोप्सी नहीं लेनी है नहीं कर, लेकिन जितना पॉसिबली आप लेस डैमेज करेंगे क्या आप स्ट्रिपिंग करके लेके खत्म कर देते हैं? नहीं कर. सो उतना ही करें जितना मेरा ख्याल है कि don't consider it a malignancy. Doing surgery to improve the quality, not to finish the disease. So improve the quality. आप इस पे जो है press करें to provide this quality.
सर सर तो खाओ में जैसे आप बताओ होता है.
So we had a wonderful presentation today by Dr. Sana, and I would like to thank Brigadier and Bar for joining us today. So this is a small presentation on how to manage allergy with a newer compound that is in the market, Bilastine. So we know the burden of disease affecting the lives of more than 500 million people worldwide, and the prevalence is around 10 to 30%. The clinical evaluation suggests that the plan should identify the specific risk factors, and the determinants of low adherence to treatment can effectively lead to the symptom control and the allergic disease is the facilitator of the allergic response, that it is raised in patients with allergy.
Antihistamines are the first lines we usually give to the patient. So we have second generation H1 antihistamines, and we know that the difference in drug specificity or active transporter proteins across the blood-brain barrier. Some second generations may enter the CNS, and then we can see the sedative effects. So bilastine is an ideal oral H1 antihistamine. It has the highest number of doses, and it also is into the cardiac, and it is non-sedative. So you can recommend this to the patients. And there's also a research that has given us an evidence that it is an optimal drug. H1 receptor, and then it does not interfere with the cytochrome P450 system, and bilastine does not affect the driving ability, cardiac conduction, or athletics. So 20 mg OD is the dose for allergic rhinitis, and it no significant changes in the So we can prove that bilastine meets the current criteria for management of allergic rhinitis. It comes with the name of Gustavo, who has helped us today. Now, Professor Johnson. आपको लग रहा है very complicated.
मैं तो सवाल भी कीमत कितनी है?
On the behalf of the ENT department and from all my lecturers, sir, thank you so much. So, मैं बड़ा enjoy किया हमने आपके learning skills को और आपके experience को. हम आपको दोबारा भी invite करेंगे. बहुत बहुत शुक्रिया सर, thank you very much. तो हमारा एक छोटा सा टोकन होता है.
Picture में pictures. दोबारा भी बुलाएंगे सर.
Welcome, no problem.
Thank you, sir.
So I feel honored. Thank you.
Yes. Sir, time आपको ऑक्सफोर्ड लाएंगे.
जी sure.
सर एक तस्वीर बनानी होती है.
जी सर.
इधर ही सर.
Patient. First control.